Hello. Picture this. A patient presents with acute, crushing chest pain. You reach for nitroglycerin. But are you absolutely certain about the one contraindication that could turn a standard intervention into a catastrophic event? Welcome to the Dr. Mech series. In this explainer, we're providing a high-yield clinical review of nitroglycerin, specifically for practicing clinicians. Now, as always, this content is for educational purposes only, and it's based on the comprehensive summary from Open Anesthesia.
All right, let's get right into the core principles, the absolute must-know clinical information you need when using this drug.
So at its very core, what does nitroglycerin do? Its main job is to relax the smooth muscle in blood vessels. It predominantly targets the veins, making it an incredibly potent vasodilator, although you'll certainly see effects on arteries too, especially at higher doses. And this is why it's a go-to for acute relief and prevention of angina. Okay, if you remember only one thing from this entire review, make it this. This is the single most critical safety warning. Giving nitroglycerin to a patient who is also on a PDE5 inhibitor, think sildenafil, is an absolute contraindication. Why? Because you risk causing a profound, severe, and incredibly difficult to treat drop in blood pressure. So how does this all happen on a molecular level? Let's take a look at the biochemical cascade that gives NTG its powerful hemodynamic effects. The whole process follows a really well-defined pathway. First, nitroglycerin itself is a prodrug. It gets metabolized in the body to release nitric oxide, or NO. That NO molecule then kicks off the next step by activating an enzyme called guanylyl cyclase. This enzyme, in turn, converts GTP into cGMP. As cGMP levels rise, they activate something called protein kinase G, and this is the final key step. It inhibits calcium from entering the cell and helps pull existing calcium out, leading to that all-important vascular smooth muscle relaxation.
What's really key to understand is that nitroglycerin's effects change with the dose you give. At lower doses, you're getting primarily vasodilation. This reduces the amount of blood returning to the heart, which in turn decreases preload. But as you push the dose higher, you start to see significant arterial dilation. This brings down the systemic vascular resistance, and that means you're now also decreasing the afterload.
Okay, so with that mechanism in mind, let's see how this translates into practical, everyday use across different clinical scenarios. The applications for nitroglycerin are surprisingly broad. You have, of course, the cornerstone uses in emergency cardiac care, like for acute coronary syndrome and hypertensive emergencies, but you also see it in more specialized areas, like obstetrics, for conditions like uterine tetany or a retained placenta, where you need rapid uterine relaxation. And this versatility is really reflected in how we can administer it. As you can see, we have everything from fast-acting sublingual tablets for an acute angina attack, all the way to precisely titrated IV infusions for our critically ill patients. And then you have specific IV boluses for those obstetric emergencies we just mentioned. You are listening to the Dr. Mech series. Of course, with such a potent drug, effective use also means being vigilant about its predictable side effects and knowing exactly how to manage them. The most common adverse effects you'll encounter, things like headache, flushing, and hypotension, aren't some strange, unexpected reaction. They are the direct, predictable result of nitroglycerin's main job, vasodilation. It's crucial to counsel patients on this, especially about the potential for dizziness or even fainting from a drop in blood pressure. Now, while it is rare, you absolutely need to have methemoglobinemia on your radar as a serious complication. The classic sign, the one that should set off alarm bells, is seeing a patient who is cyanotic, they look blue, but has a completely normal arterial PO2 on their blood gas. That paradoxical finding means you need to intervene immediately. All right, let's cover two final essential clinical pearls for managing this drug safely and effectively. One of the biggest therapeutic advantages of nitroglycerin is its pharmacokinetic profile. Think about it. A sublingual tablet starts working in just 1 to 3 minutes, and its half-life is incredibly short, only 2 to 3 minutes. This combination is what makes it so perfect for acute situations and allows for such precise, easily adjustable control with an IV drip. So what about patients on continuous therapy? This is where nitrate tolerance becomes a real issue. To prevent the drug from losing its effectiveness, it's standard practice to schedule a daily nitrate-free interval. This break should be somewhere between 8 and 12 hours. You are listening to the Dr. Mech series.
Let's end by reinforcing the most critical safety point one last time. The risk of severe refractory hypotension is real. That is why co-administration with any PDE5 inhibitor is an absolute contraindication. You must always ask about sildenafil, tadalafil, or vardenafil before giving any form of nitroglycerin. This really leaves us with something to think about in our own practices. Given its unique properties, but also its very real risks, where is nitroglycerin's role headed? In an era of new cardiovascular agents, is its place in modern therapy expanding, or is it contracting? We hope this clinical refresher has been a valuable addition to your knowledge base. Thank you for joining this installment of the Dr. Make series. Make sure you subscribe and activate notifications so you don't miss our future clinical updates.